The obesity-cancer connection is not experienced equally across all populations, and for Latina and Black women in particular, the intersection of elevated obesity rates and lower access to preventive care creates a dangerous and often deadly disparity. These women are more likely to develop and die from obesity-related cancers, not because of genetics alone, but because of a complex web of socioeconomic, structural, and healthcare barriers that continue to go unaddressed. Breast and gynecological cancers, which are already among the most common malignancies in women, become even more dangerous when compounded by these overlapping risk factors. Obesity rates are disproportionately high in both Latina and Black female populations, influenced by systemic issues such as economic inequality, food insecurity, lack of safe recreational spaces, and targeted marketing of unhealthy food products. But while obesity itself is a modifiable risk factor, the conditions that drive it are often deeply entrenched. In many communities, healthy food is expensive or unavailable, and opportunities for regular physical activity are limited or unsafe. These are not lifestyle choices, they are structural outcomes. And yet, public health narratives continue to frame obesity as a matter of personal failure, ignoring the environments in which many women are forced to live. In terms of cancer risk, obesity is not a neutral factor. It increases circulating estrogen levels, promotes chronic inflammation, and contributes to insulin resistance, all of which foster a biological environment conducive to cancer growth. For postmenopausal women, this hormonal shift significantly raises the risk of estrogen-sensitive cancers, such as breast and endometrial cancer. Black women, despite having slightly lower overall incidence of breast cancer than white women, are more likely to die from it, often because they are diagnosed at later stages with more aggressive tumors. Obesity amplifies that risk and may also blunt the effectiveness of certain treatments, yet it is rarely addressed as a core component of cancer prevention in these populations. Latino women also face disproportionately high rates of obesity-related endometrial cancer and are less likely to be diagnosed early. Screening disparities play a major role in this gap. Latina and Black women are both less likely to undergo timely mammograms, Pap tests, or follow-up diagnostics when abnormal results are found. These lapses in preventive care are not random. They are tied to insurance gaps, language barriers, mistrust of the healthcare system, and a lack of culturally appropriate outreach. When screenings are missed or delayed, cancers are caught later. Treatment becomes more invasive, and outcomes worsen. Adding to the problem is the fact that medical professionals sometimes fail to fully engage with obesity-related cancer risks in minority women. Implicit bias can influence how seriously symptoms are taken, how quickly referrals are made, or whether weight is discussed at all in a constructive way. Some providers avoid the topic for fear of offending, while others reduce health complaints to weight alone, ignoring the need for cancer screening altogether. This disconnect leaves many women navigating a healthcare system that either overlooks their risk or shames them for it, but rarely supports them in addressing it. These failures are reflected in mortality statistics. Black women are more likely to die from breast, cervical, and uterine cancers than any other group in the U.S., even when adjusted for income and education. Latino women, while having lower overall cancer incidence than some groups, are seeing rising rates of obesity-linked cancers and often lack access to early intervention. These are not just health disparities, they are preventable tragedies rooted in systemic neglect. Solving this issue requires more than urging weight loss. It demands culturally relevant, community-based interventions that address both obesity and cancer risk in tandem. Outreach programs must be rooted in the realities of the communities they serve, not just translated into Spanish or framed around generic wellness advice, but built on trust, representation, and lived experience. Healthcare providers must be trained to approach obesity with empathy and clinical precision, understanding it as both a risk factor and a reflection of structural inequality. If public health efforts continue to ignore how obesity and cancer disproportionately harm minority women, then these preventable deaths will persist. The statistics may be alarming, but behind them are real lives, families, and futures cut short. Recognizing the obesity-cancer connection in Latina and Black women is not enough. We must act on it with the urgency and justice it demands.